Well, okay, welcome everybody. I have the pleasure of giving the last word. Okay, today I'm going to present CognoCare, developed by iActive Intelligent Technologies in the University of Granada. I originally became aware of their work because CognoCare won twice from the WFMC Adaptive Case Management Global Excellence Awards, both in 2012 and 2014. The problem with traditional BPM approach is one of predetermination. In a controlled environment, like a factory, you can decide to follow the particular best path. In some aspects might be arbitrary, but with all that matters is that you follow a single path. Any deviation from that path and you're lost. The predefined fixed business process is fragile in the face of unanticipated emergencies. The path has assumptions about what happened before and what will happen in the future. What's needed is an approach that can account for deviations at any time. We know that medical care is unpredictable. Procedures, drugs, research results are changing all the time, and every patient is different. Of the 10,000 diseases one might have, every person on this planet has a unique combination. This is a serious challenge. So CognoCare provides a unique individualized treatment plans that fit individual patients while assuring that legal and customary guidelines are followed. They have codified all the rules into different rules, and there's a big logic structure that generates the processes on the fly. Not simple if-then-else rules, but instead programmed in a prologue-like language and able to make inferences about the situation, find the best combination of accents for a plurality of possibilities. We will consider a patient that has two diseases at once, diabetes and hypertension. There's rarely a specialist who can deal with both. No single doctor who knows best. They have to collaborate at some level. Now our patient is Maria Smith. A primary care physician is Kate Flanders. Kate refers Maria to Emily Alden for the diabetes and Frank Campbell for the high blood pressure. Maria will interact with each of these three doctors, and the doctors will share information with each other. Now, sharing information is tricky. Kate, Emily, and Frank don't work for the same institution. They don't use one big system. Information must transfer between separate systems, but at the same time, protect the privacy of the patients, and guarding their sensitive health information. Now, the specialists will each come up with a treatment plan that looks a little bit like these, the best practice guidelines from two different domains. The problem is that one treatment might interfere with another. Some differences are arbitrary and some are important. And how do you tell which? So discard the idea that there's a single best plan, knowable in advance. The plan is always a moving target, and the patient almost never follows the plan. The solution is to iterate, continually regenerate the plan with the latest updates. We envision a system where doctors use intelligent agents to converse with each other. Each doctor trains their agent for their specialty. Those rules may come from professional organizations in their specialization, and they'll be customized to some degree for each of their practices. The exchange starts with Kate requesting support from the specialist. The agent then gives the two specialists access to the case and essentially delivers the patient data to the agent of the specialist. The agents then access their knowledge base of rules and generate two things. First, they generate an initial treatment plan on their own, and then the agent will also identify a subset of the rules that are found relevant to this patient and pass those to the other doctor. They will then generate a conciliated plan from each of their own rules combined with the subset. Finally, the conciliated rules are passed back to Kate. The plans might not and probably won't be exactly the same, so Kate has to look over them and make final determination for the patient. Now, in actual practice, there's three phases of care. First, there's diagnosis, next is stratification, and then comes treatment. In each of these phases, they use different rules, and it cycles through the doctors. Over the course of the treatment, the patient may return many times to redo the cycle to update the treatment plan based on progress and test results. So we demonstrate a system configured to generate processes on the fly with cooperation of two or more agents. We show that agents can merge their plans and to resolve conflicts. The result is not that we're replacing doctors, but enhancing their ability to treat people. Ultimately, this is a trend towards digitized healthcare, aided by apps on the patient's smartphone, which can then feed real-time data back to the doctor and possibly updating their treatment plans in real time. To actually implement this as a multi-party system, we would need a case exchange protocol, we would need some common rule format for interoperability between vendors, and of course, not all the doctors are going to have an automatically generated plan, so we need to deal with that as well. So in the future, we might see personal assistants interacting with other personal assistants, cloning and synchronizing projects with large-scale processes emerging from that interaction.